This next case is of a Borden type 3 transverse sigmoid dural AV fistula. We ended up embolizing this with onyx. This is a 56-year-old male with tinnitus, dizziness, and bilateral whooshing sounds over the last 2 years. On CTA and MRA, he was found to have a complex Borden type 3 dural arteriovenous fistula involving the transversoid and sigmoid sinuses. There are multiple feeders arising from the bilateral vertebral arteries, external carotid arteries, and internal carotid arteries, as demonstrated on this MRA. While multiple approaches are reasonable, we elected to proceed with transarterial embolization of this AV fistula. Here we can see the guide catheter being advanced through the aortic arch into the carotid artery. Here we can see persistence of the fistula from the middle meningeal vessel. Under high magnification road mapping techniques, we now deliver a microwire and microcatheter into one of the last remaining feeding pedicles of this arteriovenous fistula. You will note that prior embolization was done in multiple stages. You can see that at this point the microwire is being used to access the middle meningeal vessel, and the microcatheter is then being brought into the vessel following the microwire. Under high magnification road mapping views, the microwire and microcatheter are being delivered to the point of the arteriovenous fistula. It is important to try to deliver embolisate into the venous portion in order to get optimal occlusion. Therefore, we continue to attempt the most distal portion, or the most distal possible access with the microcatheter. Microcatheter runs demonstrate that we are well positioned at the fistula, and at this point we're ready for WADA testing. And should he pass the WADA test, here we are delivering onyx. You can see that multiple branches feeding this fistula are being embolized. The onyx is flowing beautifully throughout the pedicles and from the arterial phase into the venous phase. We continue to inject as we keep our eyes on the reflux of the catheter. There is some slight reflux, but this is clearly tolerable. Here you can see that there is occlusion of the fistula. We do not see any more contrast in the venous phase, and now the catheter will be removed. More onyx is being deposed, and one more branch that was found proximally in order to shut this fistula down permanently. Here you can see onyx being injected from a more proximal location in order to get some of the more proximal branches. We are able to tolerate significant reflux given the fact that we are in external vasculature, specifically the middle meningeal vessels. We would not tolerate this degree of reflux if we were in the intracranial circulation. Angiogram here shows complete occlusion of the fistula for an excellent result.